So when looking at our review for our safety exam, or the one that's up in black, it is going to be a repeat from the IV safety worksheet that you completed and turned in. But this gives you some more stuff to go back and review and stuff to look up in Blackboard or in ATI as you're studying for your exam. So ABO compatibility is listed at the top of your list. You do need to know your ABO compatibility well. You have a few questions on your exam regarding ABO compatibility. This is one of the charts that is up in Blackboard, and there is this chart. I don't know, when I pulled it up right now, it looks kind of funky, but I think it downloads good. Pick whichever chart that you understand better or whatever works better for you. I like this table. That's just, it makes more sense to me. So let's say you have a test question that is, you have an AB positive person and they tell you, I can only receive AB positive blood, that's my blood type. And you receive O negative blood from the blood bank. Can you safely administer that blood? Yes, you might have to educate your patient that they can receive other blood types or that they're the universal recipient. Let's say you have another question, like your patient says, oh, I'm the universal donor, but I don't know my blood type. Of course, we're going to do a type and cross to see what that person's blood type is, but you as a nurse, if they're the universal donor, you already know in the back of your mind that they're an O negative. And let's talk about RH factor. So let's say your recipient is A positive. Can they receive A negative blood? So anybody who's positive can receive the negative blood because they do have that RH factor present. So just going back a little bit on blood compatibility, if you don't have a good understanding on it, go back. You do need to know these tables because you do have a few questions where you'll have to know if the blood type, the donor blood is compatible with your recipient's blood. So do go back and look at this. So IV complications and how to intervene. So you do have this images that we did go over in class. Please be able to identify them or that picture or a similar looking picture if you see it on an exam. Go back and look at this table also. So infiltration. Our catheter dislodges or the catheter penetrates the vessel all the way through the vein. So this is causing fluid to go in the interstitial tissue or the subcutaneous tissue and not in the vein. So that explains our signs and symptoms. We have that swelling, that pallor, the cool and pain around the insertion site, and the decreased flow rate. With this, we discontinue the infusion and restart at a different site. So phlebitis is trauma from the catheter. It could be chemical trauma from the solution or contaminated by microorganisms. Localized tenderness, redness, warmth, and mild edema of the vein and above the insertion site. We want to discontinue the infusion, apply a warm, moist compress, restart the infusion at a different site. In addition to that, that's not listed here, that you should write down, is you want to remove the catheter from that site, you want to notify the provider, and you want to document everything that you see and everything that you've done. Thrombus, trauma from the catheter or needle, same as phlebitis. Also, flow may stop if clot obstructs catheter. Same as for phlebitis, do not massage or rub the affected area. Embolus, air enters the vein through infusion line. Thrombus dislodged from insertion site and travels. Dependent on the location of any infarction caused by the thrombus, cerebral or pulmonary, perhaps dyspnea or sudden pain. Report any sudden pain or breathing difficulties. Prevention, Monitor the site regularly. Do not allow air to enter the infusion line. So our infection, we're going to see fever, chills, malaise, pain, swelling, inflammation, or pus at the insertion site. So infection, what caused the infection? It's poor sterile technique in inserting and caring for the insertion site or contaminated solution. Discontinue the IV. Discontinue the infusion. Notify the PCP. Prevention is sterile technique in initiating IV. Change dressing and tubing according to agency policy, usually between 24 and 72 hours. Speed shock, infusing fluid to rapid and into circulation, pounding headache, rapid pulse rate, anxiety, chills, back pain, dyspnea. Discontinue infusion immediately, report symptoms to PCP, monitor vital signs, prevention, check flow rate often. Fluid overload, too large a volume of fluid infused into circulation, dyspnea, engorged neck veins, increased blood pressure. Slow the infusion rate, notify the PCP, monitor vital signs, prevention, monitor flow rate and total volume I's and O's. So blood transfusion reactions, go back to your IV or your concept of safety IV skills worksheet. Our blood transfusion reactions, almost every single one we stop. The only one that's stopped temporarily is a mild allergic reaction. And then if it's a mild allergic reaction, the flushing, itching, and hives stop temporarily. Give antihistamines as ordered. If the symptoms are mild, you restart slowly. But any other, any type of reaction, you stop. We stop it. And then let's look at some other reactions, like our acute hemolytic. So that's we're gonna stop the infusion immediately. We take all the blood tubing down up to the catheter hub. But go back, look at your concepts of safety IV skills worksheet and review your blood transfusions reactions. But a big thing that you do need to know is if you suspect a blood transfusion reaction, you stop it. You stop the infusion. IV site complications and how to intervene. I'm sorry, that's a duplicate. Blood administration, timeframe, steps, required paperwork. So our timeframes. Let's think about our timeframes. So let's look at this. We get our blood from the blood bank. We need to start that infusion within 30 minutes. If we do not start that within 30 minutes, or we don't think we're going to be able to start that within 30 minutes, we need to return that blood to the blood bank. We want to start the blood within 30 minutes to avoid bacterial growth in the blood. Another time frame to think about to avoid bacterial growth is we want to administer our blood 4 hours that we start it. So let's say I start my blood at 6 in the morning. It needs to be complete by 10 a.m. Our steps required. So one of the first things I'll do is if I see I have an order for blood, I'll check that order. We ensure consent is signed. You're going to make sure consent is signed before you start priming tubing, before you go get blood, before you do any of that, because if you don't have consent and the patient's going to refuse the blood anyhow, there's no reason to prime tubing or go get blood. IV catheter insertion. So when when we're inserting the catheter, we start from distal and work our way proximal on the body or on the arms. If On our catheter insertion, we choose our gauge based on what we're going to use our needle for, and anything else with our patient. If they're very young, we might need a smaller catheter. If they're older, we might need a smaller catheter. And we know that we can advance that catheter when we see blood in that flash, we see that little flash of blood. IV catheter removal. If I'm going to remove a catheter because it's time to insert a new catheter on my patient, I am going to make sure I have my new catheter inserted and functional before I remove the old catheter. When I remove that catheter, I'm going to apply my gauze or my cotton over the insertion site, and I'm just going to hold it there. And as soon as the entire catheter is out, I'm going to apply pressure. I'm going to inspect the catheter and make sure that it's intact. If there's a little piece of the catheter for some reason broke off or is still in the patient's arm, you're going to apply a tourniquet proximal to that arm so that that little piece of the catheter doesn't enter systemic circulation, and you're going to notify the doctor. Another complication that could occur in removing an IV catheter is, let's say my patient is on anticoagulants and they do have that prolonged bleeding time. You may need to apply pressure after you remove that catheter for a longer period of time. If the bleeding persists, you can always raise that arm above the level of the heart to aid in that bleeding stopping. Flow rate, I did list that on your review, is you're going to need to be able to calculate flow rate. Let me grab it. So when we think about our math problems related to IVs, I'm just pulling up the calculator really quickly on my phone. So let's say we have somebody who has an IV going at 75 an hour, and I'm working a 12-hour shift. At the end of my 12-hour shift, if that fluid ran continuously at 75 an hour for 12 hours, what do I need to document as my ins for that IV fluid? So I would document 900 mils. IV insertion considerations in the older adult. There's an asterisk and there's some rationale here. Securing and stabilizing an IV catheter and dressing of an older adult client can be challenging due to the client's fragile skin. The nurse should apply a skin protector solution to the dressing prior to dressing the IV site to help protect the skin. Additionally, the nurse should use mesh gauze to cover the site, not rolled type gauze. The nurse should avoid using tape as this increases the risk for injury, and stretch gauze can be rolled over to secure it. Application of lotion and hair, securing the device and stabilizing the IV catheter. So going back to that, so you insert the IV. You can use a skin protector like Skin Prep, like around the IV site, and then put the transparent dressing on top. This rationale is also saying like you could use like a stretch gauze to secure it to decrease the risk of tape. And we don't use lotion because then your tegaderm's not going to stick. So you do have to cover this with a transparent dressing or tegaderm. Use some Skin Prep. Don't use lotion before you try to stick your tegaderm to the skin because then it's not going to stick. Air in line versus occlusion. Air is the pump is detecting air in the line. Occlusion, the pump is meeting some sort of resistance. Blood products, red blood cells given to increase oxygen carrying capacity of the circulatory system due to acute or chronic blood loss. Albumin is given to replace volume after acute loss, especially in patients who have severe burns and who are developing signs of edema. Known as a volume expander. Plasma given to correct coagulation deficiencies and or to reverse the effects of warfarin. When we were going over the IV worksheet, we did mention like warfarin. Like, how do I know my patient has had too much warfarin? Their INR is going to be really high. IV considerations in elderly. I think we've gone over that a few times. How do you know if IV needle is in the vein and you could advance the catheter when starting an IV? Again, we see that blood in the blood flashback chamber. What do you do if the exposed end of IV tubing becomes contaminated? So that's that little part at the end that you're actually screwing into the needle-free port. If that becomes contaminated, you need to throw it away and get a new set. IV 10 cc syringe to flush lines because we don't want to create a large amount of pressure. We start IVs distally and work our way up or more proximal to the body. So our types of catheters, what are your types of central venous access device catheters? So you have your centrally inserted catheters, and there's two types. You have your non-tunneled centrally inserted catheters, you have your tunneled centrally inserted catheters, and then you have your peripherally inserted catheters or our PICC lines and our implanted ports. And sites that should be avoided, like we talked about, we could avoid hands, especially like in the elderly or ambulatory patients. With ambulatory patients, they might get caught on something and pulled out. The AC, if we can possibly avoid it, just because it's that area of flexion, and every time the patient is going to bend their elbow, it's going to bend the line and occlude it. We don't use mastectomy sites. We don't use infected sites because we don't want to introduce that infection into systemic blood flow. So what are our tasks that we can assign to our nursing assistant, or what can I ask a CNA to do in the hospital to help me when it comes to like IVs or administering blood? So the CNA can report any cloudiness or precipitate in the IV solutions. The IV solution looks funky, they can let you know. They can report any alarms of the pump or the electronic infusion device. So if the pump is going off, they can let you know. Can the CNA turn off the pump? No. They only can report any alarming of the pump. They can report client complaints of discomfort, pain, bleeding, burning, swelling, anything like that. They can report it to the nurse. And they can report to the nurse if the fluids are almost empty, like if the patients or the CNA or the nursing assistant personnel is in the room providing care for the patient and they know that, hey, that bag is almost empty. They could go let the nurse know, like, hey, that bag's almost empty. I'm not sure if you might need to go replace that. And that concludes the review for our safety exam. Please let me know if you have any questions.